Our next guest, Dr. Richard Loftus, normally comes on to talk to us about the COVID-19 pandemic. He is, after all, our favorite infectious disease doctor. But I wanted to talk to him about a study that I saw that sort of struck a chord with me, and it's because I have kids. First of all, doctor, thank you for being here. The Mayo Clinic did a study with 4,500 infants and toddlers. And what they discovered over the years is that as little as one dose of antibiotics in that early age group would add to the chances for some childhood disorders that include asthma, obesity down the road, and basically a litany of other disorders. Tell me about what you know about that study, and as a parent who's given my kids plenty of antibiotics, I mean, how concerned should we be with these findings?
Yeah, so this was a really interesting study. It was very well done. And, you know, it's funny, as I was reading this, I was thinking, you know, scientists use the word association and lay people translate into cause. And I'll explain that in a moment. But, you know, we do have to interpret studies like this with a little bit of a grain of salt. But this was a very well done study. It looked at 14,000 kids in a county of Minnesota. They followed them for a long time. At the minimum, they followed kids for 9 years. And their hypothesis was as follows. This study was really about the microbiome, which means the microorganisms, the bacteria that naturally live in our intestines. And we've known for, you know, I mean, this has been a hot topic of research for the last, you know, decade to decade and a half. There has been an appreciation that these microbes that live in our guts actually aren't just passive bystanders. They actually are intimately involved in how our immune systems function and how our metabolism functions. We started to recognize that the microbes in your bowels can influence your risk of getting obesity, for example. And so we know that the microbiome has a big role in how healthy our bodies are and potentially how people develop different diseases. But, you know, this study was looking at whether giving antibiotics to kids in their first couple of years, and, you know, 70% of the kids in this study did get antibiotics, you know, probably I'm guessing for ear infections, which are common in little kids. Although, you know, one of the weaknesses of the study was they didn't do a close analysis of why the kids were getting antibiotics, just they got them for some reason. But what they were figuring out from doing this was that as they followed kids over time, the exposure to the antibiotics seemed to be associated with the development of allergic conditions like asthma and eczema. The antibiotics also seem to be associated with their risk of developing celiac disease, which is an intestinal disorder that affects the absorption of nutrients. And they also looked at things like the risk for autism, and also obesity or being overweight. And what they found was that indeed, you know, the greater the level of exposure in kids before the age of 2, the higher the risk was that kids would go on to develop some of these conditions. So you know, you know, if you ask any prescriber of medications, any doctor or nurse practitioner or PA, they'll tell you we really try not to give antibiotics unless we really think that the benefits are going to outweigh the negatives, because all medications have the risk of side effects.
Right.
So we try not to just use them casually. We try to only use them when we really think the benefits are going to outweigh the negatives. I think if a little child had a serious bad infection, we certainly, you know, wouldn't want them to risk getting, you know, seriously sick from an infection. That's an appropriate use for antibiotics. But I think the message of this study is that indeed, you know, there can be negative consequences to using antibiotics. So it means that we really have to be sure that we're going to treat an infection. We shouldn't just use them casually when we're not absolutely clear that there is an infection that needs medication to prevent it from getting worse.
Right, but certainly,
you know,
but parents will certainly tell you, and I, for one of them, you take your kid in because they're sick. The doc says, well, it's a virus. But if it turns into an infection, come back in 3 days, and then we'll talk about antibiotics. And it's like, we got jobs, you know, we got other things to do. Can't you just give the kid the antibiotics now? And if it's a virus and it doesn't help, it's not going to hurt. And if it does turn into an infection, well, the antibiotics are already in them. So that's sort of the parent's logic, or at least this parent's logic. What's the fault in that thinking?
Well, the problem is that, it may mean that a lot of folks who are going to get better, on their own, are going to instead get antibiotics that maybe they didn't compellingly need. And we now know that there could potentially be a downside, because if you do that, even just one time, that does measurably raise the risk of some of these chronic conditions developing later. But we may, what they did see in the study was that the more often that kids got antibiotics in that pre 2 years of age, zone, the more likely it was that they would develop some of these other conditions. What was interesting about the study too was which kind of antibiotic actually had an effect on the risk for different chronic conditions later in childhood. So I think the message is kind of consistent with what doctors and medical practitioners have been saying for a long time, which is, we really only want to use the antibiotics when we're sure they need them. Now, personally, in my own practice, when I have patients, I assume that it's a hassle to get in to see me. So my philosophy is, well, let's talk it out, let's make some plans, and maybe our initial plan is no antibiotics, but we can check in by a phone visit in a couple of days, or my medical assistant can talk with the family, and if someone indeed got worse, we maybe have already decided what our antibiotic plan is, and we can call that in and get it started. I think what you're getting at is, you don't want to risk that potentially it is going to turn into a bacterial infection that's going to make the kid pretty sick, and why waste time? And I think what I would say is the solution to that is just better logistics. So if somebody does in fact look later like they absolutely need it, that's the time to call it in and use it, because then it's clear that they absolutely do need it, and not to necessarily pull that trigger prematurely.
Yeah, even before this study from the Mayo Clinic, let's be honest, getting a script for antibiotics out of your pediatrician, you were much more likely to get them to give you a $100 bill than you were to get them to give you a script, right? So do you think now it's going to be even more likely that people, or doctors specific, will be really slow or more hesitant to prescribe antibiotics, at least in that 2 to infant age range?
Yeah, I think this will give a little bit more weight to what we do anyway, which is try to counsel and educate patients and families about the potential downsides of doing an antibiotic. I always tell my medical residents, patients don't come in necessarily because they need an antibiotic. What they need is a solution to what's going on. It's just that our lay public always thinks antibiotic because that's about as much medicine as they know. There was a campaign in the internal medicine community a number of years ago for respiratory infections to try to prescribe people inhalers to treat their symptoms, because that's what they wanted, was to feel better, and not just resort to an antibiotic that our literature told us wasn't actually going to make them feel better, and probably had a risk of the negative side effects of antibiotics. Certainly now that we're seeing more drug-resistant organisms and complications like C. diff, which is a toxic diarrhea syndrome often provoked by antibiotics, especially in older patients, we already appreciate that there are downsides to using the antibiotics. They're not risk-free. So what I think we have to do as a medical community is meet patients where they are, understand that they need a solution, and that maybe the best solution won't necessarily be an antibiotic that may not help and may even hurt. We just need to come up with treatments that can make people feel better, because that's really what the patients are coming in for. And certainly in the case of little children, it may be that this research, for example, leads to ideas about, if we do need to use an antibiotic, can we also give little children probiotic supplements to rebuild parts of their biome, their microbiome, that might be adversely affected by the antibiotics they're being given if they absolutely need them. In other words, could we mitigate the negative effects of these antibiotics based on what we're studying? And I think that's possible. We probably need to learn a lot more about the microbiome to know how to do that. But this does point to the possibility that we may be able to reverse those negative effects of the antibiotic while giving the benefits of using them in people who really need them.
He's Dr. Richard Loftus. If it's infectious diseases, he's your guy. Thank you, sir, as always, for your time.
Always a pleasure, Gino. Thanks.
Thanks, Doc.